Hi there, my highly valued, treasured and esteemed viewers and listeners. Welcome back to your channel of choice. My name is Dr. Nap Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 129 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. And the first question reads, patient OMW, a 75-year-old, presents to your accident and emergency department complaining of right-sided chest pain and a productive cough. He also complains of progressive shortness of breath lasting 48 hours. This patient now requires increased use of salbutamol inhaler. He has a past medical history of hypertension, type 2 diabetes mellitus, coronary artery disease, and he is also asthmatic. He has no known drug or food allergies, and he hasn't received any vaccinations or antibiotics over the past 1 year. On physical examination, the physician establishes the temperature is 39.1 degrees centigrade. He has a blood pressure of 134 systolic, 76 diastolic, with a heart rate of 87 beats per minute and a respiratory rate of 32 breaths per minute. He is desaturating slightly. The oxygen sats are 90%, and closer examination shows crackles in the right lower lobes. Chest X-ray is done, and right lower lobe consolidation is observed. And this slide depicts some of his pertinent labs, so I would recommend you pause the video and scrutinize it closely. Now, his PSI, pneumonia severity index, is 92 points, and the PORT risk class is 4. So my question to you is, which of the strategies listed below would be the most appropriate in OMW's management? Would you choose to admit this patient and treat the patient with vancomycin and ceftriaxone? Or would you discharge the patient and treat with oral moxifloxacin 400 milligrams once daily? Or would you admit the patient with Ceftriaxone plus Azithromycin? Or would you discharge the patient on oral Azithromycin 500 milligrams once daily? I'll give you 10 seconds to choose the correct answer. I would choose to admit this patient and treat with the Ceftriaxone plus Azithromycin. Now remember, OMW has a pneumonia severity index score of 92 points, and this places him in pneumonia outcomes research team, what we abbreviate as PORT risk class 4, and he scores a CAP 65 score of 3. That is, his age is above 65. His respiratory rate exceeds 30, and his BUN is above 20. And that suggests hospital admission is appropriate in his case. And that makes choices D and B incorrect because they both refer to outpatient treatment. Now, intensive care unit can be considered, but is likely unnecessary in my opinion, since OMW does not have severe CAP. There are no major severe CAP criteria which include vasopressor or mechanical ventilation use, and he only has two minor severe CAP criteria, which are a respiratory rate above 30 breaths per minute, the BUN above 20 milligrams per deciliter. Now, OMW is hemodynamically stable and is not showing any signs of end organ failure, so I would not rush him to the ICU. Then I would like to add that choice A, that is vancomycin plus cefepime, does not provide coverage for the common atypical bacterial pathogens associated with community-acquired pneumonia, such as Mycoplasma pneumonia, Chlamydophila pneumonia, or Legionella species. And it is overly broad. It covers MRSA and Pseudomonas. Therefore, it would not be a suitable choice for this particular patient. Then, I would just like to remind you that the MRSA and the Pseudomonas are unlikely causes of CAP in this particular patient who has no risk factors for those pathogens. I would like to add that Ceftriaxone plus Azithromycin is appropriate because it will cover both the most common typical pathogens such as strep pneumo, Haemophilus influenzae, Moraxella catarrhalis, and it will also cover the atypical such as Mycoplasma, Chlamydia, and Legionella. So it would effectively cover the community-acquired pneumonia in this patient's case. Let's move to the next question. Still referring to the above patient, OMW's cough, shortness of breath, and chest pain improve after 48 hours of antibiotic therapy. He was able to eat his breakfast unassisted this morning. Physical exams are done and his temperature has fallen to 37.1 to be precise, degrees centigrade. His blood pressure is 138 systolic, 80 diastolic. His heart rate is 75 beats per minute, and the respiratory rate has fallen down to 19 breaths per minute. He's saturating well at 97%. The chest is clear to auscultation. The labs are depicted there. I would refer you to the bottom of this slide, so you can feel free to pause it for a while as you scrutinize it. So OMW's expectorated sputum grew strep pneumo, which had an MIC of 4 for amoxicillin, and it was classified intermediate. It was susceptible to ceftriaxone with an MIC of 0.5. It was susceptible to azithromycin with an MIC of 0.25. It was susceptible to levofloxacin with an MIC of 1, and it was also susceptible to vancomycin with an MIC of 0.25. So my question to you is, basing on the results above, which of the regimens listed below would be the most appropriate for patient OMW now? Would you treat him with a gram of amoxicillin administered orally thrice daily for 5 days? Or would you treat with a gram of ceftriaxone infused over 30 minutes once daily for 3 days, 3 more days that is? Or would you treat this patient with the 750 milligrams of levofloxacin administered once daily for 3 more days? Or would you treat him with IV vancomycin targeting trough concentrations of 15 to 20 milligrams per liter for 3 more days. I'll give you 10 seconds to choose the correct answer. I would settle for C and treat him with 750 milligrams of levofloxacin orally once daily for 3 more days. Now the current IDSA and American Thoracic Society CAP guidelines recommend patients with CAP transition from IV to oral antibiotics when they are hemodynamically stable or when they are improving clinically and are able to ingest oral medications, or when they have normal functioning GI tracts as well. Now we are told OMW was able to eat breakfast, he's hemodynamically stable, so he satisfies all these criteria at this time. And that makes the IV therapy in choices D and B unnecessary from an AMS point of view. And just like to add that data indicates that the appropriate minimum duration of antibiotic treatment for a patient with the CAP is 5 days, provided that the patient is not showing more than one CAP-associated sign of clinical instability. That is, if the patient is febrile, the heart rate is less than 100 beats per minute, and the respiratory rate is below or equal to 24 beats per minute, and the systolic blood pressure is above or equal to 90, the arterial oxygen saturation is above or equal to 90%, and the PO2 is equal to or above 60 millimeters of mercury on room air, or if the patient is able to take food orally, and the mental status is normal. Now, after 2 days of therapy, we are told OMW is febrile and he has no CAP-associated signs of clinical instability. Thus, apart from subsequent clinical deterioration, AZ is a candidate for 5 days of antibiotic therapy. And this makes choice A, that is oral amoxicillin for 5 more days for a total of 7 days of therapy, incorrect. That would be too long. Then we are left with the choice C, which is levofloxacin, 750 milligrams once daily orally for 3 more days. Now this antibiotic and dose have been shown to be effective in a randomized controlled trial of patients with community-acquired pneumonia. Let's move to the next question, please. And it reads, 42 days ago, same patient above, OMW, successfully completed his antibiotic regimen, though he declined to receive the seasonal influenza vaccine prior to his discharge. Today, 42 days later, he returns to your hospital complaining of nasal congestion, cough, mild shortness of breath, subjective fever, malaise, and chills, which have lasted the past 3 days. Influenza A virus is revealed following a rapid reverse transcriptase polymerase chain reaction, what we abbreviate as RT-PCR assay of the nasopharyngeal swab. On physical examination, his temperature is found to be 39.1 degrees centigrade. He has a blood pressure of 130 systolic, 80 diastolic. He has a heart rate of 75 beats per minute and a respiratory rate of 18 breaths per minute. He is not desaturating badly. The SATs are 97%, and when his chest is examined, there are diminished breath sounds bilaterally. So my question to you is, which course of action listed below would be the most appropriate in this clinical scenario of OMW? Is it true that no antiviral treatment is indicated? Is it true that we should give oral amantadine? Or should we administer inhaled zanamivir? Or should we settle for oral oseltamivir? I'll give you 10 seconds to choose the correct answer. I would opt for oral oseltamivir. Now, in patients with risk factors for influenza-associated complications, the IDSA influenza guidelines recommend the use of antiviral medication for influenza, regardless of time from symptom onset to minimize risks of complications. Now remember, OMW is above the age of 65 and has comorbid respiratory disease. He's asthmatic, he has a heart disease, he has CAD, if I remember well, and even metabolic disease, type 2 diabetes mellitus, all of which are considered to put OMW at a high risk of influenza complications. Thus, in my opinion, antiviral treatment is indicated, and though it's indicated, choice A is incorrect. And choice B, amantadine, is also incorrect because the adamantins are no longer recommended for the treatment of influenza due to widespread resistance of circulating influenza strains to this medication, the adamantins. That is rimantadine and amantadine. Now, choice C, in my opinion, is also incorrect because inhaled zanamivir is not recommended in patients with underlying respiratory disease such as asthma, COPD, and so on and so forth, because of the risk of bronchospasm. Now, zanamivir also has less clinical data, and it may decrease the incidence of influenza complications relative to oseltamivir. So, oseltamivir appears, in my opinion, to be superior. That makes answer D the correct answer to this question. Let's move to the next slide, please. And it reads, Mrs. OKJ, a 75-year-old female patient, is brought to your accident and emergency department from a nursing home where she resides. The chief complaint of a new onset altered mental status, left-sided weakness, and a facial droop. Provisional diagnosis of hemorrhagic stroke is made, and it requires craniotomy. This patient is stabilized after the craniotomy, though she remains mechanically ventilated. 6 days after admission to your hospital, she remains hypoxic and experiences increased tracheal secretions. She has no known drug or food allergies, and she has a past medical history of urinary tract infection caused by Escherichia coli, which was treated with a 7-day course of ertapenem, 1 gram, infused over 30 minutes, and that was done 35 days ago. So my question to you is, which of the approaches listed below would be the most appropriate to determine if patient OKJ has ventilator-associated pneumonia? Would it be use of clinical criteria, serum procalcitonin concentrations, and clinical pulmonary infection score? Or would it be use of clinical criteria and clinical pulmonary infection score? Or would it be use of clinical criteria and serum procalcitonin concentrations? Or would it be the use of clinical criteria alone? I'll give you 10 seconds to choose the correct answer. So D is the correct answer. Use of clinical criteria alone. Remember the current IDSA and the American Thoracic Society guidelines for the management of adults with hospital-acquired and ventilator-associated pneumonia recommend that diagnosis of VAP be based on clinical criteria alone. I would refer you to read it. Now, biomarkers such as procalcitonin and the clinical pulmonary infection score lack clinical outcomes data demonstrating their efficacy and safety in diagnosing nosocomial pneumonia and have sensitivity and specificity below the 90% threshold set by the expert panel for recommended use in diagnosing both VAP and HAP. And that makes choices B, C, and A incorrect in my opinion. So this table refers to results belonging to patient OKJ above. I would recommend you pause the video and scrutinize it closely before proceeding to the rest of the question. So based on this clinical data, hypoxia and tracheal secretions, a presumed diagnosis of VAP is made, and the figure below shows the antibiogram of the neurologic ICU at your hospital as per 2021 data. It shows the percentage of isolates susceptible, so I would also recommend you pause this video at this point and scrutinize it because it will help you make the correct choice of antibiotic for the therapy. So my question to you is, basing on the information on the neurologic ICU antibiogram shown above, which of the regimens listed below would be the most appropriate for patient OKJ? Would it be Piperacillin-tazobactam 4.5 grams infused over 4 hours alongside Tobramycin and Vancomycin, or would it be Piperacillin-tazobactam infused at the same dose and rate plus Vancomycin alone, or would it be the same dose of Piperacillin-tazobactam plus Tobramycin alone, or would it be monotherapy with Piperacillin-tazobactam 4.5 grams infused over 4 hours 4 times daily? I'll give you 10 seconds to choose the correct answer. I would settle for A and infuse Piperacillin-tazobactam plus Tobramycin plus Vancomycin. Now, according to the current IDSA and the American Thoracic Society guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia, patients with risk factors for MDR VAP should receive empiric coverage of MRSA and double coverage of Pseudomonas aeruginosa. Now, remember, this patient has received IV etapinem 5 weeks ago, and the VAP onset is after 5 days of hospitalization. So, OKJ, in my opinion, has 2 risk factors for MDR VAP. Now, the ICU unit where he contracted the VAP also has MRSA prevalence of above the 10 to 20%, which is also an indication for MRSA coverage, and that makes choice D wrong because it lacks both MRSA and double pseudomonas coverage. Remember, Piperacillin-tazobactam does not cover MRSA, and it is monotherapy for Pseudomonas aeruginosa. So D is the wrong answer. Then choice C is incorrect because Piperacillin-tazobactam lacks MRSA coverage. As much as we can cover Pseudomonas using Tobramycin, then answer B lacks anti-pseudomonal coverage. Remember, we are using just Piperacillin-tazobactam and Vancomycin, so we are not covering Pseudomonas using double anti-pseudomonal coverage. We require Piperacillin-tazobactam plus a second anti-pseudomonal antimicrobial agent. So covering with monotherapy plus MRSA coverage alone does not suffice. Just like to remind you that OKJ has the following risk factors. He had a terpenem for the treatment of a UTI in the past 90 days. He is in septic shock, he has sepsis, he has renal failure, and even the serum lactate is above the 2 milligrams per deciliter mark. Then he has been hospitalized for over 5 days before the onset of this case of VAP. Let's move to the next question. So this slide shows the patient's details on the internet as of today. So I would advise you to pause it and scrutinize the slide in relation to the next question. So basing on the above results, which of the regimens listed below would be the most appropriate treatment for VAP in OKJ's case? Would it be Tobramycin, or would it be B, meropenem plus Tobramycin, or would it be C, Ceftolozane-tazobactam, or would it be D, meropenem monotherapy? I'll give you 10 seconds to choose the correct answer. I would treat this patient with meropenem monotherapy. Now the current IDSA and American Thoracic Society guidelines for the management of adults with HAP and VAP, directed treatment of patients with Pseudomonas aeruginosa VAP should be based on antimicrobial susceptibility testing. Now evidence for most anti-pseudomonal agents does not demonstrate superiority of any one agent over another. Now the exception is the aminoglycoside monotherapy, which is not recommended due to lack of evidence to support their use in this manner in the management of VAP caused by Pseudomonas aeruginosa. Now some clinical evidence even demonstrates inferiority of aminoglycoside monotherapy for serious infections other than the urinary tract risk factors. That's choice A, Tobramycin, is incorrect in my opinion. I would like to add that choice C, Ceftolozane-tazobactam, is incorrect because evidence of this novel agent in pneumonia is limited to non-comparative observational studies, making it less evidence-based than the standard anti-pseudomonas beta-lactams like meropenem, which is alternative D. I would like to add that choice B, that is meropenem plus Tobramycin, is incorrect because the pathogen is susceptible to meropenem and this patient is not in septic shock, so monotherapy would do. And I would like to add that guidelines only recommend directed combination therapy against Pseudomonas aeruginosa, HAP, or VAP in patients who remain in septic shock due to potential mortality. Now, in such patients at risk, we can use combination therapy. There is benefit in using combination therapy and not monotherapy. And, let's move to the next question, please. And it reads, a curious medical resident inquires why you, as the clinical pharmacy specialist in the infectious diseases team, recommend meropenem in the management of OKJ's VAP and not Ceftolozane-tazobactam. So my question to you is, which of the responses listed below would be the best answer to this gentleman's question? Would it be A, there are few clinical data supporting the use of Ceftolozane-tazobactam in patients with VAP, or is it B, Ceftolozane-tazobactam should be reserved for Pseudomonas aeruginosa infections caused by organisms resistant to standard monotherapies such as meropenem, or is it C, there are few clinical data supporting the use of Ceftolozane-tazobactam in patients with MDR Pseudomonas aeruginosa, or is it D, Ceftolozane-tazobactam is not FDA approved for pneumonia? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Ceftolozane-tazobactam should be reserved for Pseudomonas aeruginosa infections caused by organisms resistant to standard monotherapies such as meropenem. Now, I'd like to begin by saying that Ceftolozane-tazobactam has been approved for HABP or VABP based on a randomized controlled trial demonstrating non-inferiority of Ceftolozane-tazobactam relative to meropenem for HABP or VABP. That makes choices A and D incorrect. Now, in this trial, while few of the patients had multi-drug resistant Pseudomonas aeruginosa, observational data suggests Ceftolozane-tazobactam is associated with improved clinical cure and reduced acute kidney injury compared with, for example, colistin or aminoglycoside-based combination therapy regimens for MDR and XDR Pseudomonas aeruginosa. Now, I'd like to add that half of the patients in this trial had VABP. Now, there are also multiple non-comparative observational studies describing experience with Ceftolozane-tazobactam for MDR Pseudomonas aeruginosa. Thus, choice C is incorrect in my opinion. I would just like to remind you that it's important to reserve Ceftolozane-tazobactam for infections that are resistant to all standard monotherapies, including the carbapenems. Now, this is because most anti-pseudomonotherapies are considered equally efficacious for HAP and VAP. Thus, there is no clinical benefit for using Ceftolozane-tazobactam over meropenem. Now, I would like to add that unnecessary use of Ceftolozane-tazobactam will likely hasten the development of resistance to this novel product, and it will limit our options in the future. Now, since Ceftolozane-tazobactam is one of the few agents that retain activity against MDR and XDR Pseudomonas aeruginosa, Ceftolozane-tazobactam resistance would leave patients with highly resistant Pseudomonas aeruginosa infections without an optimal antimicrobial therapy. So we should reserve this antibiotic as much as we can. Let's move to the next question, please. And it reads, OKJ has already received 5 days of appropriate targeted antibiotic therapy for Pseudomonas aeruginosa. He becomes hypoxic and febrile. There is an increase in his tracheal secretions. His primary nurse sends his tracheal aspirate to the microbiology lab for culture. Later that day, the clinical microbiologist calls the primary physician, informing him that the dreaded Acinetobacter baumannii has been cultured. Tragic news indeed. And the tracheal aspirate grows Acinetobacter that is resistant to Piperacillin-tazobactam, resistant to cefepime, resistant to meropenem, resistant to azithromycin, resistant to unacin, sulbactam, and piperacillin, resistant to Tobramycin, and only susceptible to colistin with an MIC of 1. Bad news indeed. So my question to you is, which of the regimens listed below would be the most appropriate for patient OKJ, considering the culture results reported by the clinical microbiologist in the above table? Would you settle for inhaled polymyxin B sulfate, or would you choose IV polymyxin B sulfate, or would you settle for IV polymyxin B sulfate and inhaled colistin, or would you settle for colistin monotherapy administered IV? I'll give you 10 seconds to choose the correct answer. I would settle for IV polymyxin B and inhaled polymyxin E, colistin or colistin method sodium. And I'll explain to you why. Now, the current IDSA and American Thoracic Society guidelines for the management of adults with HAP and VAP recommend the use of a combination of inhaled and systemic antibiotics for HAP and VAP due to MDR gram-negative bacilli susceptible only to aminoglycosides or the polymyxins. Now, although it's not explicitly stated in the guidelines I've just mentioned, the predominance of evidence for inhaled antibiotics for VAP involves the use of systemic therapy to which isolate is susceptible. Now, for this Acinetobacter baumannii isolate in the above table, that would mean that both an intravenous and an inhaled polymyxin be used, and that makes choices D and B incorrect. Now, choice A, in my opinion, is incorrect because inhaled polymyxin B is not recommended due to lack of supporting clinical evidence. Most literature quotes the use of polymyxin E, colistin, and not polymyxin B. Now, polymyxin B is also thought to result in more histamine release and bronchoconstriction when nebulized. So I would not use it for nebulization at all. That makes answer C the correct answer. Nebulize colistin and infuse polymyxin B. Let's move to the next question, please. And it reads, the primary physician streamlines OKJ's therapy appropriately for the Acinetobacter baumannii. Then 7 days later, OKJ is no longer hypoxic, is no longer febrile, neither does he have increased tracheal secretions. So the outcomes are good, very promising indeed. The WBC count has also normalized, and the primary physician is skeptical, about discontinuing antibiotic therapy after only 7 days, despite the IDSA guidelines recommending the same. My question to you is, which of the criteria listed below would best guide this physician on when to best discontinue antibiotic therapy in OKJ's clinical scenario? Would it be A, use clinical criteria, serum procalcitonin concentrations, and clinical pulmonary infection score, or would it be B, use clinical criteria and clinical pulmonary infection score, or would it be C, use clinical criteria and serum procalcitonin concentrations, or would it be D, use clinical criteria alone? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would opt to use clinical criteria and serum procalcitonin concentrations. Remember, the current IDSA and ATS guidelines for the management of adults with HAP and VAP recommend serum procalcitonin concentrations be used in concert with clinical criteria to guide antibiotic discontinuation in patients with either HAP or VAP. Now, this is based on clinical evidence applying procalcitonin concentrations in this manner in patients with VAP, resulting in shortened antibiotic durations without differences in clinical outcomes to suggest it is unsafe. Now, due to lack of clinical data, antibiotic discontinuation based on clinical pulmonary infection score is not yet recommended. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And I thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in the next video. Thank you very much.